So I met with Michelle ahead of time and she is out actively working in the field. What I mean by that is she's doing on-site mock surveys across the nation and is putting together reports of problem areas within the clinic to help them address and problem solve areas of non-compliance. And one of the biggest areas of deficiencies at clinics, even to this day, is medication handling, specifically single dose versus multi-dose vials. And so what we thought would be helpful is to give you some resources that you can take back to your clinic setting, implement it for your staff educational opportunities, put it into your onboarding processes, whatever you think will be helpful, but going through the details of what's expected in relation to the physical plant, the policies, and general infection control practices within the clinic when it comes to medication handling. So we're going to review some safe practices for storing and administering medications. We're going to look at the policy requirements for your pharmaceutical policy. That is probably one of the most robust policies that you'll have at your clinic. And then we're going to talk about some of those common deficiencies that are found in relation to medication. That's okay. We can use buttons. Thank you. So here's the rules. Now, I am one that has to come from somewhere, right? I don't want to just give you the information and say, this is what you have to do, go do it. I want you to know where the information is coming from so that you have that backbone, that back support, that information of why this is important at your clinic. Because that's where you're going to have staff buy-in, if you will. I'm not just telling you this because you have to, here's where it's coming from. And so I pulled language directly from Appendix G. That is the state's guidance of how you have to be surveyed and how the surveyor will measure you. This, of course, also relates right into if you're using one of the accreditors, the compliance team or Quad A, they adhere to these same areas, even though they have their own written standards. Everything is kind of across the board, if you will, in relation to medications.
Some technical difficulties. Good. Also,
We'll keep going. So where we have the information directly is in the law for the RHC is 491.6. And this is the actual written rules and regulations that the clinic has to follow. And then I pulled in some slides from Appendix G, and that's the interpretive guidelines of how you're measured to determine if you're in compliance with the law. 491.6, the main piece I want to pull apart here is drugs and biologicals are appropriately stored. How many think that's a very broad statement? There's a lot of nuances within that of how you're actually going to determine, am I being successful in this? Same with the next area, premises are clean and orderly. There's a lot of gray area within that statement. So we have a very short law, but a lot of interpretation within that. And so my goal is to give you the resources to be able to meet the highest standard within that. Okay. So in relation to Appendix G, again, this is the interpretive guidelines that supports how the law is measured. It talks about appropriate storage for drugs and biologicals. And our famous statement is we always defer to manufacturer's guidance for use. Now that kind of seems like a pass the buck statement, right? Essentially, I can't tell you every single medication that you have in your clinic exactly how it has to be stored, monitored, distributed, logged. I can't do that for every single medication. That's not my expertise. What I can do is say every medication has a manufacturer's guidance on how it needs to be stored in relation to humidity, in relation to temperature controls, in relation to security, depending on the type of schedule it is. There is information directly related to that drug based on its makeup, based on its preservatives or lack thereof, of how long it can be stored and what is the appropriate process for administering that medication. So yes, it sounds like we're passing the buck when we tell you to look to the manufacturer's guidance, but that really is your go-to resource to know the timeline. How good is this medication viable? If it's an open date requirement, if it's multi-dose, if it's single dose, Does it require an open date? Is it good for 28 days? Is it good beyond that to expiration? It is unique to every single medication. We like to simplify things and just say across the board, if you use 28 days as your default for every medication that you're administering in the clinic, then you'll be successful because that's the basic. That's usually the base that we come back to. But then we get specific medications that are very expensive and it's hard to throw them away at 28 days. So if you can find documentation from the manufacturer that extends it beyond that 28 days, usually we see language to expiration, even after it's been opened, and you have that documented, you can store that medication beyond the 28 days. But we come back to that default of 28 days unless you have documentation from the manufacturer that extends that expectation. So that's our go-to deferment, if you will, is we defer you to the manufacturer's guidance. Make sure you have that available, that your staff know the expectations and appropriate practices within that. Then it says it may not be readily accessible. So then we talk about security. When we do a mock survey, we walk through the clinic and we're looking to see, are your medications, sharps, chemicals, PHI, and biohazards secured throughout your clinic space? Medications being one of the highest areas. Appendix G has a lot to say about what's considered secured. So we're going to dive into the nuances of that because sometimes it's impossible to have a lock on a unit. It doesn't fit within the workflow of the facility. So then we talk about line of sight, person being a barrier, or a lock on the clinic, and that's where we come into the spectrum of compliance. And we're going to dive into that in detail in a little bit. This slide I wanted to give you specifically because it talks about that line of sight being in a specific office area or present where other staff members are, who's allowed to access your meds, or being under lock and key. So coming back to the law, we talked about the storing of drugs and biologicals. Then we have to talk about policy. Because I don't know about you, but some clinics we work with, they have 110 policies, they have 150 policies, they have over 300 policies and multiple binders upon binders upon binders. And really, the pharmaceutical policy can be just one policy. It's quite lengthy. And we're going to dive into what should be captured within that pharmaceutical policy. But there are elements you have to capture, but it comes back to what's required. And the law specifically states that you have to have a policy defining how you store, distribute, and dispose of medications and administer, sorry. So here's the language from Appendix G regarding that development of the policy. And it talks about storage of drugs. And one of the things that we find is clinics have a hard time securing meds because where that lovely refrigerator is stored, it gets really, 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 really hot because it's a tiny little confined space and the ventilation in that space is just not appropriate. So they can't really have the door closed or they change the entire temperature of that space. Therefore, the meds that aren't in that refrigerator unit are no longer viable because they were in an environment that was too hot for the temperature requirements. So that's where we come into these mitigation strategies of line of sight, person always being a barrier, who has access, making sure that there's constant visual of that space, and we'll dive into that. But when you're considering where you store meds in your clinic, you have to consider all of these areas. Does it approve for sanitation? Does it meet the clean versus dirty standpoint? Are we keeping elements segregated within that? Where are we drawing meds and administering meds? What about temperature and light and moisture, ventilation, segregation, and security? So these are all considerations as you're determining in your clinic space, where is it safe and appropriate to store our medications? Then security. Now, some states have very strict requirements of who can access medications, especially depending on the types of medications you store at your clinic. If you have controlled medications, that has even higher standard of who has access. How do you know that the meds that you have in your inventory stay at your clinic and are not removed from your facility without your knowledge? Who's accessing those meds? Are they secured? Especially the emergency kit, that's probably one of the elements we find most often is not kept in a secure area because we think emergency, we think easy access, we think grab and go ready. And it does need to be grab and go ready, but it still contains medications. So it still needs to be secured yet accessible. And that's one of the problem-solving strategies that we need to talk through. So I often find them in a locked medication room. So badge access, you put a key or a code in, you get in, everything in that space is secured. Patients cannot access that space. That's usually the most convenient for staffing, but it can be expensive to put key codes in, right? Some put them in a provider office. And so that office is secured because the person is in there or it's in constant line of sight. Some put them in a locked cabinet, but I've been in clinics where that locked cabinet, we don't know where the key went. We can't find it. So is it accessible, right? I had one clinic that had a different key for every single cabinet in the room. Oh, it was like the janitor comes through and you cannot figure out how to get in that cabinet. So again, yes, it's secured, but it's not accessible. If a patient was in distress, we would not be able to address their need. So we have to find that balance. We have to find that line, make sure that we're allowing for security of the medications, yet accessibility for patient need. That continues with security, record keeping. So at the end of this presentation, I like to provide tools, I like to provide resources, not just tell you what to do, but here's how you can actually accomplish it. So we have some specific logs that you can use for sample medications, controlled medications, monitoring temperatures at your facility. We have some additional resources at the end. One element I do want to bring to the forefront is handling of medications. One element we find often when doing a walkthrough is pre-drawn syringes of medications. They weren't from the manufacturer that way. The nurse did it at the beginning of the day to do a flu clinic. By the time we walk through about 1 o'clock, there's still a nice little plastic basket with syringes with pre-filled medications in it. Oh boy, that's a major area of deficiency because there's nothing to say that that's going to maintain its viability for that duration of time. There's nothing to say that it has the appropriate preservatives to maintain its viability for the time that you have it sitting in that unit. So unless the manufacturer sends them that way, pre-filled, they need to remain in their initial packaging until it's ready for patient use. Expiration. Now, I tried to put red in because I wanted to pinpoint specific areas. You'll notice this entire slide is red. The reason is probably any clinic that gets a deficiency, majority of the time somewhere in that plan of correction is an expired item. Who says they have had that experience? Yeah, it's low hanging fruit. It happens. It's hard to keep track of everything that's in your space on a consistent basis. Sometimes our providers hide things in their carry-all that we don't realize are in there, or sometimes they're in the back of a cabinet that's covered in dust and we haven't been in that space in a while and we forget there's items in there that expire. So we see this on a very consistent basis where medications specifically are beyond use, are beyond date, have expired. And so really making sure that we have assigned accountability of who's monitoring the spaces where we're storing our medications. Who is that person on your team that's really good at keeping things organized, making sure that they have responsibility over that space, that it's assigned and it's not just assumed that it's being reviewed, and keeping track of where are our medications and making sure that it's not beyond use. A couple of slides from now, I have a decision tree that you can use. A lot of clinics put it right in the cabinet where they handle their medications. And it gives the way to tell what the beyond use date is based on if it's a multi-dose or single dose vial. Basic safe practices. I'm sure all of you have heard of the 5 R's for administration of medication: right patient, right dose, right medication, right route, and right time. That should be directly in your policy, but it also needs to be trained with staff that are administering your meds. Do they know the proper protocol for confirming that the patient is getting the medication they're supposed to have? So here we go into some FAQs. What is considered secure? That's probably one of the biggest questions Michelle and I address when we're on site with a clinic, is we're constantly surveying the space. One, is it safe? And two, is it secure? So when we walk into where a clinic stores medications, we look around and we see what are the access points to this space? What are the security measures to this space? Is there a lock on the door? Is there locks on the cabinets? Is it in a provider heavy traffic area, maybe in a nursing station where there's always someone present? Or is it in a potential area where a patient could walk into that space, no one would see them, and they could walk out with a kit full of medications? We've seen it. We've seen that kind of situation with Sharp specifically. Used needles is a huge issue, especially with the opioid crisis the way it is. Supplies leaving the clinic without the clinic ever knowing it. So when we walk in and we're looking to see if it's secure, it's not just because the government tells us we have to, it's because it's for your patient safety. But when you're looking at security or security of medications, we like to look at the compliance spectrum. So when I walk in, if I'm preparing you for your initial survey, my confidence is way high if I know everything is under lock and key. I know we are good to go. There is no way you're going to get a deficiency as long as you monitor outdates and single dose files. But if it's under lock and key, it is secured. It's not always practical. So then we come back to, we're moving a little bit further away from the definitely good, definitely compliant, but line of sight is appropriate. If it's in a high manned area that's constantly under line of sight, a person is considered a barrier. But you have to be cautious. You can say this nursing station is busy, there's always someone present, but if the surveyor walks through and sees that space empty and medications out and accessible, it's not considered secure. What happens after you close the clinic for the day? Housekeeping comes in. Are medications secured at the end of the day if they're not in locked areas? So really considering all of the access points to those medications, who has access, is it appropriate for them to have access, and is it safe? We had a clinic that was provider-based. They actually were embedded in the hospital, and the procedure room was carved out because of access. I'm not going to get into the commingling side of it, but anyway, they got a deficiency from Joint Commission because they had multi-dose vials in a procedure room. That's not an RHC standard. That is a hospital standard. But because they shared space, they had to adhere to both. And so really thinking through, is it safe to administer to my patient? Is this secure? Do we know that there's no cross-contamination of this space? And thinking through each of those elements in regards to where you're storing your medications. I like to simplify it and say, lock the room or lock the stuff. So if you can't lock the whole space, we have lab areas that have needles where it's an open door. There's no door to the space. And it's impossible to put in a door because of the workflow and the fire hazards, right? And so then it's the process of wherever sharps are stored, medications are stored, it's locked, the cabinets are then locked. So it's lock the stuff or lock the room. What is considered appropriate infection control protocols? So we actually had a clinic that came to us that had a deficiency because the medications were stored above where the labs were handled and processed. And so they had the cabinet of medications here, and the space that was designated as clean to draw up the meds was stacked full of supplies, and they could not actually use that dedicated clean space to do the drawing of the medication. So the visual implication, meds are in the cabinet, here's the counter with urine and blood spinning thingy. I know there's a technical term for it. And it looked like that's where they were drawing up their meds because that's what the MA said they were doing. That's cross-contamination. That's not segregating the clean from dirty. Really making sure that we separate, segregate, all of those terms that are in the Appendix G language, our clean elements from our dirty elements, having appropriate signage, having appropriate visuals, having space to be able to complete those tasks. I had another clinic that I did a mock survey for, and one of our discussions is they had their lab sink, they had their centrifuge, they had their lab fridge with their biohazard sticker on it. And then they had their clean counter here, but there was no room on the clean counter because their computer took up all the space. So where were they drawing up their meds? They were putting a clean pad down on the counter in front of where all of this stuff was spinning, things were splashing. It was not a clean space. They had their labels, but there was no actual space for them to do the work. So we talked about putting up a splash guard. We talked about reallocating the space and making sure that they could clearly define those areas within their clinic setting. Injection safety, making sure that we have built into our onboarding, our annual training, proper infection control techniques, aseptic techniques with those that are handling medications and administering meds. Where, how, and when should meds be drawn up? We already talked about those pre-drawn syringes, making sure that that's not done unless the manufacturer sends them that way. And then avoiding the cross-contamination. So what are clinics actually getting deficiencies for? Well, common deficiency is inappropriate storage. Lots of people have access to the drugs, not having them stored in appropriate spaces. And then probably the highest deficiency is having an open single dose vial. You can see the cap has been popped off that vial. There's been a needle inserted into that vial and then it's put back onto the into the cabinet. That is condition level automatic deficiency. Even if everything else in your clinic is completely perfect, that one thing will fail you and they have to come back again. It is the top deficiency. It is something we still see throughout the nation on a consistent basis. And I really think that, especially with my background as an educator, we can do so much to disengage that by providing more education and by making sure that as we bring in new staff, they understand the expectation and understand the differences between a single dose and a multi-dose vial. Inappropriate administration, not following the 5 Rs, not documenting everything. If we're administering meds in the clinic and the patient visit, it needs to be documented in their record as well. And then not having appropriate documentation across the board, especially if you're distributing samples. FYI, formula is a sample. Pediasure is a sample. It has an expiration date. You're distributing it to your patients. There could be a recall. We had a recall on formula not very long ago, last year, I think. If you're distributing it to your patients, it's a sample. It needs to be captured on that sample distribution log. Yes.
Press it back to, were you referring to a single dose vial still having something in it? Or
Yes.
are you, okay, you're not referring to a multi-dose vial?
No, a single dose vial that still had a little bit of liquid at the bottom.
Okay.
They put it back into the cabinet.
Okay.
No, I appreciate the clarification because we want to make sure there's understanding across all of these. So here's your policy. If you are building a pharmaceutical policy, or if you already have a pharmaceutical policy, use this as a checklist and make sure you can go back and say everything that's in this checklist you've covered on how you're going to handle each of these areas. So storage, talk about temperature, humidity, ventilation, make sure that you have appropriate storage units for your medications. And having it defined in policy what the expectation is for storage of medications. Security, how do you secure your meds? Who has access to your meds? Who's approved to access your medication storage areas? Power outage. This should be reflected in policy on how you transport meds, if you have a backup generator, who your power company is, where you transport your meds to, that you have written agreement there, or at least proof that you can that they would accept your meds if you had to transport, that you have the appropriate supplies on site to transport, but where do you transport your meds? Having that clearly defined in written policy. That needs to be in your policy manual, and if you're through the compliance team or Quad A, it should also be in your emergency plan. I think it's good practice regardless of who your accreditor is. Administration, at least the 5 Rs are listed in your policy. What is the process so that when your staff refer back to policy, it's clearly written what the protocol is. One I find missing often is recall. It is a requirement that you define how you handle a recall. Who's responsible for communicating with patients about that recall? It doesn't just get deferred to pharmacy unless it's prescription, obviously. But what about within the clinic? If you have samples, how is it documented? How would you communicate with the patient to let them know it's no longer safe for them to go through that process?
How long do we have to keep the sample logs?
So recommendation is survey to survey. However, I know some states are beyond 6 years. So if you go beyond 6 years, usually 6 years is the threshold because that's the expectation for medical record storage. If you're through the accreditors, you're on a 3-year cycle of survey, so you don't have to store it as long. Distribution, again, this is more relevant if you're handling samples or controlled meds, making sure you define how you distribute them, what documentation expectations you have for tracking the variables and all of that. Disposal, how do you dispose of meds? Are they put into the biohazard container? Do you have a pharma box? Do you work directly with the pharmacy? Do you have a courier service? What is your process for removing medications from your facility? Putting them in the trunk of the provider's car is not appropriate. Controlled medications, what is the expectation for agreement between the patient and the provider so that there's not abuse there? Do you have a contract? Do you have an agreement? What is the process? Who's responsible for monitoring the volume of your controlled meds and making sure there's no variances there? And then documentation. If you say you're gonna do, you have to have the support that you're following your written policy through logs and other elements. So here's the helpful table regarding why single dose and multi-dose vials are different. I would put this right into your educational elements that you do for onboarding anyone who's handling medications at your clinic. Even if they're the only one, if they're only looking at outdates, they need to know how to know if the medication is still good to keep it in the clinic. So this is a great resource. This came directly from CDC. This is not Tressa created. This is from CDC's One and Only campaign. And make sure that they understand the difference between why it's labeled as single dose versus a multi-dose unit. And it all comes back to preservatives. Multi-dose vials have a preservative in it that keeps the viability of that medication longer. Single dose vials do not have any preservatives. So we are giving patients unsafe medication if we're reusing a single dose vial. That's why it's a condition level deficiency. Now, survey readiness. I'd like to work with clinics and tell them, here's what to expect, because it kind of takes the blinders off the eyes a little bit and gives you that sense of, okay, we're good. We got this. Survey's not so scary. What kind of questions could the surveyor be asking your staff? They come through and they're observing hand hygiene, they're observing glove use, they're observing that draw of medication, they're observing all of this, but they also ask questions. And so these are helpful ways for your staff to know how to respond if you give them these questions up front. If clinic finds a vial out of compliance, so say for instance, you're doing your environmental rounding, right? And you see that lovely single dose vial put back in the cabinet. My recommendation would be to go and pull the VIN number or the lot number. That's what the word I want. Sorry, not VIN number, that's vehicle. The lot number off of that vial and look it up within your EMR. Because if you're tracking who you're administering it to, it should pull every patient that medication was given to. I would do the same with any multi-dose vials that don't have an open date. Pull that vial, look up the lot number and see who all that medication was given to. Is it beyond the allowed amount of doses? Is it beyond the 28 days for those multi-dose vials? And is that single dose that was put back in the cabinet, was it given to more than one patient? Go through that process if you find that vial, because then you can determine what kind of patient mitigation strategies you need to come up with to make sure that you are reporting appropriately if there was a safety incident. And that's what the surveyor will do with you as well. If they find that within your cabinets, they're going to have you pull that lot number and determine the severity of the patient safety breach that happened. Observe administration techniques. Do the training with your staff and then observe how are they doing with following the protocols. Do they go through the process of the 5 R's? Are they looking at to determine if it's still a viable medication? Are they going through those decision trees in their mind and are they following proper aseptic techniques? Have they cleaned their areas? Are they doing it in the clean area or are they working over where the lab stuff is? And make sure you're observing, because that's what the surveyor is doing as well. And it gives you the ability to address issues early on instead of it being a persistent issue. When is medication no longer considered viable? Ask these questions to your staff that are responsible for administering meds. How do they know that it's no longer a viable medication? And let them address that question with you. How do you dispose of medications? Because they're the ones that have to follow policy, right? Make sure that they're following your written policy once you have that defined. What's the difference between a single dose and multi-dose? Make sure they're able to come back to you and say the preservatives or however you want them to define that. So that they know how to recognize the differences. Who's responsible? Because I don't know about you, but when a surveyor's asking me that, I'm gonna say the person next to me. But if they're assigned to that cabinet, if they're responsible, there's accountability within that, and you can make sure that they are reviewing that space on a consistent basis. Now, one of the reasons I say pre-made kits is because I had a clinic that went to the nursing home to do visits, and the provider had a pre-made kit that they take with them. And in that kit is where we found all of the fun things. They had multi-dose vials that didn't have an open date. They had things that were really badly expired. They had the suture kits that they took an element out and put everything back in, not sterile anymore. There was just a lot of things going on in that pre-made kit. I also find it with specifically like the COVID test where you had the swab and you had the vial and all of those things. One element expired at a different time than the other element, and it got the clinic in trouble because they weren't looking at all of the things. So when you have pre-made kits, caddies are a huge area of non-compliance. Pre-made bags, IV kits, emergency kits. Who's responsible for reviewing those specific elements and making sure that they are kept current? Because what I find is out of sight, out of mind. And then make sure that once you review and develop that policy, here's everything we do for medications within our clinic. Review that with your staff and get their acknowledgement they understand. Specifically if it's relevant to their tasks. So here's those resources. There's no reason to reinvent the wheel, right? If it's already developed, use what's already there. CDC has a one and only campaign, and it goes through a PowerPoint defining the differences between the different types of medications, proper injection practices, all of those elements. Put that into your online training programs, put it into your onboarding process, whatever you want to do, but implement that into your training modules. They already have it created. It comes directly from CDC, who are the professionals within this, and use those resources to train your staff. Here is the sample distribution log, just a template that you can use for tracking the lot numbers, who it's given to. Do please take note that patient information is on this form, so make sure it's kept in a secure area that you're protecting HIPAA and PHI. So if you have a sample closet, typically is what we see, or a file cabinet with a drawer that locks in the provider's office, we typically just see the distribution log stored right in where the meds are, because if you're securing your meds, the PHI is also secured in that moment. Here's a sample controlled medication log, where you can track the variances and reporting processes you're doing to be sure what you say you have on site is what you still have on site. Please make sure controlled meds are under dual lock and key. So if the room is locked and then it's in a locked cabinet, that's considered a dual lock. Zip tie is not considered a lock. So if you have it zipped and then a lock on the cabinet, that's only one lock. This is from VFC, so it's not something we created. It's a free tool that the VFC provides on how to track the temperatures of your medications. One note I want to make is if you have a dorm style refrigerator, who knows what I mean by dorm style? Where it has the main part of the fridge and then the freezer is inside that same body, that is not appropriate for medication storage. You will get a deficiency for inappropriate storage of meds. You can use it for labs. For some reason, they don't care as much about labs, but medication viability, you cannot use a dorm style refrigerator for medication storage. And then, of course, if you have a door on the front that has space, nothing in the door of the refrigerator, usually we see water bottles, but a clinic actually got a deficiency for storing food in with meds for having water bottles in their fridge. So just label them, do not drink, not for consumption, and it removes it from the idea that it's considered food. All right, now lidocaine and xylocaine, these are probably our biggest culprits for the deficiency. Would you agree with that, Michelle?
I do.
Lidocaine being the biggest. So can you see, I'm hoping this is large enough where you can see the detail. 20 milliliters is considered a multi-dose vial of xylocaine. How many milliliters is in lidocaine for this vial? Can you see that?
20 or 30.
It says 30, and what type of medication is it? Single dose or multi-dose?
Single dose.
So you have more medication in lidocaine, but it's considered a single dose. Does that make sense? No. You're probably gonna use whatever you have to for that patient visit. There's gonna be a ton left at the bottom. So all of us, especially me, I come from a very Dutch family. I don't mean to be offensive. That is just my background, and we don't throw things away unless we have to. If it's a waste, it feels like it's horrible. But it's not viable. It's not safe. Okay, and so really make sure the first thing your staff should do when they pull a vial out of the medication cabinet is look at the vial, single dose, multi-dose, and then go through the decision tree we're gonna share in a moment. Just because the vial is bigger doesn't mean it's a multi-dose vial. I've had large vials of lidocaine come into a clinic, and then the manufacturer switches what they send to the clinic, and they went from a multi-dose to a single dose, and it just slipped their mind because it wasn't what they always had. So really going through that process of first decision is always multi-dose, single dose, and then we can go through the rest of the process. This sticker here is not a requirement, but we found it be very helpful for clinics. So having that visual on the front of the vial, that when I open a vial that's multi-dose only, that's the only place these sticker goes. When I open a multi-dose vial, my first action is to put that open date so I know how long it's viable. Because again, 28 is our default unless manufacturer allows differently. Single dose, I've even seen stickers where it says single dose and they put that right on the outside of all of their vials. So they know as soon as they puncture, they throw it away. Whatever you need to do to give your team the support that they need to be actively, visually looking at each vial and knowing if it's viable or not. I do have this symbol here on the screen as well with the circle and the 2. That means it is sterile. So if it has that symbol on it, it can only be used once. Biggest culprits there are sterile water, because you get these big bottles of sterile water for your irrigations. They use a little bit of it. It cannot go back in the cabinet. It's considered sterile until opened. That's the language we typically see. Same with steri strips, sterile gauze. If it has that symbol, 2 with the symbol through it, that is considered a single-use item. It is no longer allowed to be used for sterile purposes.
Is that true even for like cleaning your autoclave? If you have gallons of sterile water?
It would need to be, you would need to look at the specific element. You can work with manufacturer to see if they have a different type.
Like I honestly just go to Walmart and buy sterile water.
So you would want to look at the language within it. If it says anything about once seal is
Okay.
broken, it's one and done. Now I have had clinics, this is recorded, isn't it?
Yeah.
Sterile water.
Never mind. Come see me after. Awesome. Thank you. I only have a couple of decision trees. These are just for you to use within your clinic. So once they do that first decision, multi-dose or single dose, this is what their decision tree is after that. So if it's a single dose vial, is it open? Discard immediately. Is it closed? Now we see, is it expired or not? And that's the determination if they keep it or put it back in the cabinet or not. A lot of clinics put these right in the cabinet where they store their meds, and their staff are able to have a visual of the decision tree they need to do each time. Here's the same one for your multi-dose. It's a little bit more convoluted, but it's all of those action steps that they should do. Is it still viable? That's the question we're trying to answer. Is it safe for the patient to use? That is it for medication handling. Questions?
And again, those who are online, feel free to put something in the chat. I'm gonna load up the next presentation.
Question